Good afternoon, everyone. It's a pleasure to be with you. And my name is Aaron Wendelboe. I'm an infectious disease epidemiologist. I'm at the OU Hudson of College of Public Health. And I get the opportunity to represent Dr. Brassler today. And I will be giving a brief update and then followed by Q&A. So just to begin with, I really would like to convey the urgency that we are in a crisis right now. During the last 7 days, over 15,000 cases of COVID have been reported, and we all know that there's a lot more cases out there that are not being reported. As of today, there were 1,380 people reported to be hospitalized with COVID in Oklahoma. I realize that is not the highest number of COVID hospitalizations that we have experienced, but this is still a crisis, and I'm going to go through the reasons why. But before I do, I would just like to have everyone think back to March of 2020. When COVID was new, we didn't know what to do. The first public health message that I think we all heard was that we need to flatten the curve. And the reason why is we didn't want to overwhelm the healthcare system. Unfortunately, we are at that point. The healthcare system is being overwhelmed, and so we are at the same public health message, which is we need to flatten the curve again. So again, why are we in crisis even if we don't have record number of hospitalizations? Well, because before this surge, the hospitals were already relatively full of the regular illnesses and sicknesses and surgical procedures and whatnot. Also, we are short-staffed. Everyone is COVID fatigued, right? Healthcare workers are, our public health officials are, our civil leaders are, you are, I am. But we have had a drastic reduction in healthcare staff. And so this affects the number of people that can be treated in our hospitals. So we really are in a challenging situation. I'd also like to just briefly mention my transmission dynamics model. In other venues I've talked about this, but basically it's a model to try and take the information about how the cases and hospitalizations and deaths have occurred in Oklahoma, detect the trends that we're observing, and then try to forecast how things are going to happen in the future. And of course, it's not perfect, but I do try to account for things like who's been infected, who's been vaccinated, the Delta variant, the number of cases that may be happening that aren't being reported, waning immunity. I try to really account for some complex issues here. And one thing that is really standing out to me is that we're able to model the current trends and the increase in the transmission rate. So in June, we were at 2, and now we're at 4, and I'm going to explain what that means. So a 2 means that on average, each infectious person will infect 2 other people. 4 then means 1 infectious person will infect 4 other people. Now, if we were talking about money, that'd be great. I could start with $1 in my bank, and after 10 generations, I would have over $1 million. That would be like, when I talk about generations, we talk about the incubation period of COVID being like 3 to 5 days, right? Well, so that's what I'm saying is waiting 3 to 5 days. So in a couple months, I'd have $1 million. Of course, we're not talking about money right now. We're talking about people's lives. We're talking about hospitalizations and people dying. So this is really tragic. And like I said, so let me reiterate, we've doubled the transmission rate over just the last couple of months. And so this goes back to the urgency of needing to flatten the curve, because what we're observing right now is actually a steepening of the curve, right? We're going in the completely opposite direction. And the model does project that we are still on track to observe a further increase in hospitalizations, and then, of course, corresponding deaths and whatnot. So anyway, please, that completes essentially the summary of what I wanted to say. You already know how to flatten the curve, right? Mask and get vaccinated. Things haven't changed, but please do it. Oh, actually, I do have one more thing to say. I realize there's some people who just don't care about COVID. We talked about people being COVID fatigued, right? Okay, I get it. There may be some of you that are just like, I don't care. Don't talk to me about COVID. I really hope that you or your loved ones don't get in a car crash or have a heart attack or get a stroke. One of my loved ones had surgery last week. 2 days ago, woke up in excruciating pain, had to go to the emergency room, and it was completely full. He and other people were just waiting out in hallways, and no, it's very frustrating when you're in extreme pain and there's no healthcare providers to come talk to you, to reassure you, to tell you that you're next on the waiting list. And of course, this is all completely unrelated to COVID, but when a hospital's full, it's full, and we are just in a very tense situation right now. So with that, I would like to take your questions.
So I know that you don't work in a hospital, but when you're talking about the beds not being available beds, and a lot of this has to do with staffing, I don't know if people understand what that means. If we have 500 beds, we should be able to have 500 patients, but they don't understand that you can't have a dozen nurses taking care of 500 patients. I mean, they don't understand maybe the ratio. Can you just put a little perspective on that for people who that's not really maybe?
Yeah, that is going to be challenging, other than just to reiterate that as many of you know who have interacted with the healthcare system pre-COVID, that you really appreciate when you have the time to sit with a nurse, with a clinician, whatnot, and they listen to what you're experiencing, and they are able to then give their attention to help treat you. And you know what it's like to wait and that kind of frustration. But if the patient volume doubles or quadruples, and then like we talked about the healthcare staff dropping or being reduced, then the healthcare staff are still doing heroic work. They're working long hours. They're fatigued, but they are still doing their professional job of trying to get to everybody. But there's also only human. And so the end result is still just needing to wait and just dealing with the fatigue that they're experiencing.
Also, when you were talking about your modeling, what do you foresee, or does it show like on September 15th, I suspect we'll be at our peak, and I mean, do you get that kind of detail? Or?
I do. It makes me nervous to project an exact peak, just because, like I said, the model's not perfect, but emphasizing that it works best when we assume that in the near future, we'll continue to behave like we have in the recent past. So if those assumptions continue to be true, then the model is showing that we will actually peak by the end of this month. And so, I can make some changes in the assumptions to try and give some variability on, because I have some uncertainty on exactly when that'll happen. And it could peak a bit earlier, maybe a week earlier, maybe a week later. But it actually is fairly robust that, again, assuming that things continue the way they have been, that the peak will be here by maybe the end of the month.
Okay, let's get to some of these questions that we have. I don't know if you are able to project information about students, but she's asking if you have a projection for how many students in the state might contract COVID and how many might be exposed in quarantine. So I assume that maybe she's meaning the lower level students.
Yeah, and I do not have exact numbers for you to quote. I haven't done an age stratified model, but just in general, we do know that the majority of people that are being affected by COVID are the unvaccinated. And so because our children age 12 and under cannot be vaccinated and they're in school, they're being affected. And then, of course, even though those 12 to 18 can be vaccinated, but we just have lower proportions among that age group that are also being affected. And so, like I said, I don't have any official statistics about how many people have been or will be, students have been or will be infected. But anecdotally, I know that everyone that I've talked to who has kids, and I have kids in school as well, that within the first 2 days of school, everyone was given notification that their child was in a class with an infected case. Without fail, everybody said, "Oh yeah, I've heard that too." So I think it's happening right now.
We're getting a lot of questions in here. Are we going to see more of the Lambda variant, do you think? Is that eventually going to become more common than the Delta?
That's a great question, and sorry. The question is, to what extent will the Lambda variant affect us, and will we see it? It's a great question, and I don't know that anyone knows. I don't have a certain answer, but I will speculate that if we experience the Lambda, it will not probably cause the same level of surge that the Delta has, and that's based on what I've read from some other professionals, but I don't have any, I have not done any research myself to inform that decision.
This is a good one. And are we at a turning point now in Oklahoma as we are so close to reaching that 50% vaccination rate that our health commissioner says has helped other areas see reductions in hospitalization?
Certainly the vaccination has helped a ton, but 50% just isn't enough. For the longest time, you all have heard us say that we needed to get actually closer to 70%. That's what I've said. I've said 70%. And that was based on the original strain of COVID, where the R naught was maybe between 3 and 3.5. But like I said, and as you've heard, the R naught for the Delta variant is quite a bit higher, maybe as high as with chickenpox. And so the calculation for the herd immunity threshold is tied to that R naught. And so I would say that we actually need to get up to closer to 85% vaccination in order to really make that huge difference. So the need for increased vaccination has just really increased.
So this person was asking then about the R naught, and maybe it's what you just said. It kind of answers this, but he's asking about the transmission model. Is the number mentioned virus or not? Is that overall or the Delta variant specifically?
So the question was about the R naught for the Delta variant, and briefly, I'll just mention that there's two factors that I account for in the model, both the R naught, but also what's called the effective reproductive number, because these two numbers scientifically and mathematically mean different things. The R naught is more theoretical in a completely susceptible population. The latter is more applied, accounting for population behavior, masking, and population immunity and whatnot. So I try to account for both of those.
I don't know, this person that asked about the schools, she just wanted to reiterate, I think her computer cut out a little bit. She just wanted to say, I wanted to make sure I understood that whether the assumptions in the model take into account schools going back. I know you answered that, but if you could just say that again.
So with regard to schools going back, I have taken that into account, the model. It certainly contributes to an increased spread of Delta. It's not, actually, I'll be honest, it didn't make as big of an impact as I hypothesized it would. That's why it's great to have a model based on the mathematics. But yes, I try to account for the increased spread by kids going to school.
So again, I was trying to group them, but it is just coming in too fast and furious. Do you have concerns if people think the latest peak is just a few weeks off, they will continue to ignore the need to get vaccinated and just take other mitigation measures?
I am. So the question is, am I worried that if people think that the peak is only a couple weeks away, will people choose not to get vaccinated and maybe take other mitigation measures? Yes, and that's another potential reason why I'm hesitant to exactly say when the peak's going to happen, but of course I want to be 100% transparent with the work that I do. At the same time, what I'm learning, because in addition to modeling, like we're hosting conversations, education systems where we just want to listen to people with their concerns about the vaccine, and we're trying to address that with the best scientific information that we have, but just also, like I said, just listen to people. And I do think that there's a lot of people who, regardless of when the peak happens, they're not going to choose to get vaccinated anyway. But I really do hope that people understand that if you choose to get vaccinated right now, it reduces your risk of both getting sick, getting hospitalized, but potentially more important than yourself is and we've been saying this for a year and a half, but transmitting it to the people that you love. I know there's a lot of concerns about breakthrough cases, and it's happening. I don't dispute that, but it still reduces your risk by so much, and it's the simplest thing you can do, and the vaccines are safe and effective. And yeah, we do have this ongoing conversation of whether boosters will be needed, and potentially updating the vaccine, like the seasonal influenza vaccine gets updated. All of that is part of this scientific conversation. But what can you do today is to get the vaccine that's available to you.
Overlooked this one. This is a good one. Testing has gone up, but it's nowhere near as much as it should be. How are you monitoring the spread of COVID aside from just ICU bed numbers? Do you know how bad COVID is really without people being tested?
Certainly. So you're asking me, how do I account or how do I measure how many people aren't being tested? And you're right, I don't know how many people aren't being tested. I do back calculations, kind of like what you suggested. I try to account for the percent of people who are being hospitalized, percent of people who are dying, and making an expected guess, again, assuming that things would be acting similar to what we've seen in the past. So I estimate that there's probably 5 times as many cases out there as are being reported. Certainly that estimate has some error in it because, of course, we don't know what we can't measure.
And so he also is asking if you are using any of the data that's collected from the sewage research.
I do. So I'm very fortunate to work with the team here at OU that's doing that wastewater work. Dr. Kuhn is actually in my department, and so I get to work with her on a daily basis and give a shout out to the rest of the team. I do not specifically account for the wastewater data in my model, and the reason why is there are multiple models out there, and I think it's good that way because we shouldn't make our decisions based on just one model or one source of information. And so I think that when we have models from wastewater, from mine, and then other people, there's the IHME model, and there's a lot of other things. I think that when we look at those, and if we get a consistent story, then that gives us more confidence that our conclusions are the same. And so, and I can verify, I was just talking with members of the wastewater team yesterday, that they are seeing higher levels of virus in the wastewater than they've ever detected during the whole COVID pandemic. And so it absolutely underscores and agrees with the same message that we're seeing a peak surge and a lot of transmission, and we really need to flatten that curve. We need to get masked and we need to vaccinate.
So I don't have any more. I just wondered if you could maybe end with talking about just, again, I know you don't work in the hospitals, but maybe just how hard it is on those frontline workers, a year ago we were saying how tired they are and how hard they're working, and they were such heroes, and they are more so today. So in all aspects, more tired, more heroic, more everything. So I just wonder if you could maybe give a little insight into that.
Sure. Again, just for all the healthcare providers that are listening, I just want to thank you for everything you're doing. I know how exhausted you are, and I guess the other insight that I have is I have some administrative responsibilities where I sit on committees trying to make decisions about how we can best run both the hospitals or the university given the resources that we have. And time again, the concern is raised that we don't have enough healthcare staff to implement the recommendations that we would ideally like to implement. And so our hands are really tied in many ways because of the healthcare staff being stretched, being exhausted, and also just not having enough. That's it. Thank you so much for your attention, for your questions, and it really is a pleasure to be with you all.